So clearly you guys are doing a lot of cancer intervention there. What all are you guys offering in particular for liver-directed therapy?
Yeah, so we do quite a bit in terms of ablation, Y90, TACE. We just started doing histosonics like histotripsy. That's kind of another hot topic, but it's one of those things where the liver's so amazing, really, when you think about it. There's so many modalities that you can use to treat these liver tumors, and it's not like it's one is right and one is wrong. It's like you can have multiple things that are actually correct in the right setting.
Right, you can have multiple in the same patient.
Exactly. There have been patients where, I'll ablate, they have like 3 tumors and I'll ablate like 2 of them and then come back and do like a Y90 on like the third. But, to answer your question, yeah, in terms of liver directed, it's quite a bit. And it really kind of speaks to kind of, going to tumor boards and getting these patients this way and this kind of collaborative approach that we have at Columbia.
I'm glad you said that. I want to get into that a little bit more, talking about tumor board. In terms of microwave ablation, though, who are you primarily treating? Are we looking at, metastases or primary liver cancers?
Yeah, that's a great question. We kind of do a little bit of both. A lot of times we'll, obviously looking at BCLCAs, sometimes Bs. Patients who, I guess if we talked about this maybe like 5 years ago, the answer might have been a little bit different. But I think now with all the treatment modalities, I think the nice thing for patients is that we can really kind of get precise as to what would be the best treatment in this specific patient for this specific tumor. For Mets and for, liver cancers, for HCC, a lot of times now we're kind of migrating towards like the smaller tumors. They're kind of like perfect for ablation. You don't have to worry about, is a tumor too small for Y90? Is it hypervascular? Is it not? Whether you're worried about margins, if it's small, you can kind of just go to town, make sure you get your margins. And I think that's the nice thing about kind of where we've progressed, I think, in IR is we've gotten to a point where we know that, okay, if we're going to microwave this thing, like we're going to just zap the hell out of this, right? So that's, to answer your question, we do, METs as well as HCC in terms of ablation.
So when you're evaluating a patient, let's go based on imaging. What are you looking for in order to determine if a patient is a candidate for microwave ablation?
Yeah, so for microwave, I think one of the things in terms of kind of the phrase is always location, 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 right? Something that I would say, especially, starting out, something that's relatively peripheral, not necessarily at the capsule, although there is data that says that that's okay. And anecdotally speaking, we have done those tumors and they've been fine. But I guess if we were to kind of just say general, something relatively peripheral, you want to avoid, I think, kind of anything centrally. You worry about bile ducts, obviously. I still go with kind of like that 3 centimeters or less. I know with imprint, actually, what's really nice is you can actually go even up to 4 and maybe even a little bit bigger. So you have that kind of flexibility, but I generally kind of tend to, I'm a little bit more on the cautious side. So if it's like, if it's 3 or less, I'm like, okay, I can definitely get this and I can get like clear margins. So these are kind of the things that, I think about. Location as well, kind of lower in the liver, maybe like segment 5, segment 6, like those areas. Maybe for your first one, maybe avoid the ones at the dome, I'm not saying it can't be done, but it's like, maybe get a few under your belt and be like, okay.
Okay, so what's the most you're willing to treat at one time in terms of number of lesions?
I generally tend to do 2 or 2 or 1. Maybe I've personally never done 3 in one setting. I know I do have some colleagues who have, but I don't know. I tend to, I just want to make sure, maybe again, this is me being cautious. I just want to make sure the patient can handle it. They can tolerate it. Generally, I think with microwave ablation, what's different than maybe like, a radiation segmentectomy is you're a little bit more precise and you're probably taking out a little less liver. So you might be able to get up to even 3, but I call it whatever. I err a little bit on the side of caution where I just say, you know what, let's do 2 at a time. Let's see how you do. And then, we'll figure out the rest later.
I don't think I've ever done more than 2 at a time. I just don't like to do one and then reposition the patient once they're under anesthesia. I've already done half the procedure, but a lot of times if I'm looking at more than 2 lesions, I'm looking at a transarterial therapy anyway.
Exactly. Yeah, and like you said, that's another kind of consideration, right? Like you have the patient under anesthesia. Obviously it's great, if you have anesthesia, patients still and everything, you can get apnea, but you kind of want to limit how much time they're under anesthesia as well. That's another consideration. So yeah, I think the nice thing again, like I was saying before, is that we've gotten to a place where we can kind of just decide, like, it doesn't have to be all or nothing, right? We can microwave a couple lesions, we can come back, we can do something else for some other lesions.